Hello everyone, and welcome back to Step 3 High Yield. And this modality is going to prepare you simultaneously for the 80% of the questions on the exam that are single best answer questions, and the 20% that is computerized clinical case simulations. Now what we're going to do is going to go through the rheumatology chapter, and you won't see exactly every single word that you see in the book, because what you're going to see in the words on the slide here is a little bit shortened down from the book so that you can pay attention to the words I'm saying. So you're going to see a summation, a slightly abridged version of what's in the book. At the same time, we're going to add some extra things to you and liven it up. And remember, this is the most current educational material you can get, preparing you for Step 3 of your USMLE or COMLEX examination. This is the rheumatology section. And now the first part of this is rheumatoid arthritis. And the presentation of rheumatoid arthritis is generally much more common in women and a bit older. Now remember, although there's joint pain, well, osteoarthritis, if the question is joint pain, osteoarthritis is the most common cause of joint pain. And the stiffness, though, the biggest difference is osteoarthritis gets worse. The more you use it, the worse it gets. The more you use it, the worse it gets. But rheumatoid arthritis is different. You wake up stiff in the morning, and you get looser as you go on through the day. Because when you go to sleep overnight, it's like, oil can. But in the morning, it's like, and it does go on for an hour in the morning. It has to be multiple joints, and it goes on for a while, and it's more chronic. Now, here's a good question. How do you tell the difference between this and parvovirus B19? Parvovirus B19 feels very much the same, except parvovirus B19 is short-lived, just a few days. Rheumatoid arthritis goes on for a long time. And remember, there's a lot of things with weight loss and malaise. So malaise and weight loss, in addition to this, is not enough. Multiple small joints. It has to go on for a while because it takes about an hour for you to unstiffen, to unclench. It is more towards the small joints of the hands and the feet. Small joints in the hands and the feet. Small joints in the hands and the feet. Small joints in the hands and the feet, as opposed to osteoarthritis, which is larger joints, hips and knees and ankles, larger joints like shoulders. Osteoarthritis, large joints, knees, ankles, hips, shoulders. Seronegatives like ankylosing spondylitis, the axial skeleton. Ankylosing spondylitis, the axial skeleton, which is the spine and the sacroiliac. Ankylosing spondylitis. Rheumatoid arthritis is out here. Psoriatic is out here. Multiple joints, the more joints, the more likely it is. And it is more or less symmetric. Now, a rheumatoid factor, here's a weird thing, right? That the rheumatoid factor, isn't that the weirdest thing? That the rheumatoid factor over there, the rheumatoid factor is not most frequently found in rheumatoid arthritis. Isn't that weird? That the rheumatoid factor is not the most frequently found thing? That what we have is cyclic citrullinated peptide, CCCP, like formosylvia test, a cyclic citrullinated peptide, CCCP, is the most specific thing for rheumatoid arthritis. But rheumatoid factor, here's a good question. What disease most frequently has rheumatoid factor? I'll tell you later. I can't help myself. It's cryoglobulin. That's right, because a rheumatoid factor is a cryoglobulin. Now, you've got to have either a cyclic citrullinated peptide, or you've got to have a C-reactive protein or a sedimentation rate. In other words, the difference between this osteoarthritis, the difference between this and ankylosing spondylitis, the difference between this and osteoarthritis, the difference between rheumatoid arthritis and all the others is that there must be some laboratory evidence of people suffering, and these people are suffering. Some evidence of inflammation. Now, it's not just one of them. In other words, it could be a rheumatoid factor or a C-reactive protein or a sed rate, but you've got to have some laboratory evidence proving that there's real inflammation there. So rheumatoid nodules, recently in the new definition of rheumatoid arthritis, the rheumatoid nodules were made something that is the most frequent extra-articular manifestation. Which of these is the most frequent? Is it pericardium? Is it lung? Is it skin? Skin is the most frequent of the extra joint manifestations, but not necessary for the diagnosis. It's the most frequent, but not essential. Not essential to have rheumatoid nodules. Not essential. Same thing with X-ray abnormalities. Now, this is an extremely important feature. They're not necessary anymore. In other words, if you have joint erosions, if you have pannus formation, it tells you do likely have it, but the definition was changed. I can't explain to you how important this is. is because for many years, drug companies and insurers would say, you don't have joint abnormalities. We're not going to approve payment for your drug to prevent you from having this crippling disease. And people would say, but wait a second, I need that drug to prevent the crippling disease. And they go, yeah, but you don't have an abnormal x-ray. Yeah, but I need the drug to prevent the abnormal x-ray. And they'd be like, yeah, but you don't have the abnormal x-ray, do you? So you don't have rheumatoid arthritis, so we're not paying for the drug. It's kind of like somebody saying, you're hungry, come back when you're not hungry and we'll feed you. So you don't have to have x-ray abnormalities anymore to be defined as rheumatoid arthritis. You have multiple joints, morning stiffness, SED rate or C-reactive protein, rheumatoid factor or cyclic citrullonated peptide, and the fact that it goes on for 6 weeks or more. Now, the most common of the manifestations outside the joints is not cardiac. It's not cardiac. It's not lung. It is not blood. It is not nerve. It's actually skin. Now, cardiac pericarditis, valvular disease happens, lung disease happens, and it's characterized by the lowest glucose level of any pleural effusion. The lowest glucose level of any pleural effusion. And it's not just lung nodules, not just skin nodules, but lung nodules. And anemia, this is the classic normochromic normocytic anemia, the classic normochromic normocytic anemia. And nerves, mononeuritis multiplex. What does that mean? Is it mono? Is it mono or is it multi? Is it mono or is it multi? And the interesting thing is, it's kind of like, I had neuritis at a multiplex. No, what this is that this is something characteristic of vasculitis. In other words, vasculitis is something that where you have large nerves, nerves large enough to have names, and you have more than one. I got an ulnar and a radial. I got a perineal. I got a perineal and an ulnar. I have multiple nerves that are large enough to have names. See, the usual peripheral neuropathy, like diabetic peripheral neuropathy, the usual peripheral neuropathy, like diabetic peripheral neuropathy, is something in which people just have numbness and tingling and numbness and tingling. They're small nerves, small nerves. They're small nerves that make it so that basically you have a glove and stocking abnormality, you don't feel things symmetrically, and it's a little numbness, a little tingling, a little numbness, a little tingling. This is different. This is like zap, a little wrist drop, I got a radial and wrist drop. Zap, I got a foot drop, foot drop, foot drop. And that is big nerves, big nerves. Skin nodules occur, but again, they aren't necessary for the diagnosis. A 34-year-old woman with pain in both of her hands for a few months, stiffness that improves as the day goes on. That's the key feature. That has to be improves as the day goes on, improves as the day goes on. Man, there's more than one joint. She's clearly got erosion. She's clearly got rheumatoid arthritis. So which is the most accurate test? And out of all these, the most accurate is cyclic citrullonated peptide. Remember, rheumatoid factor is sensitive 70 to 80%, but not specific. SED rate is completely not specific. Okay, waiting at a line too long make my SED rate go up. ANA is, of course, completely non-specific, and all you see in a joint fluid aspirate is a couple of thousand lymphocytes, The rheumatoid factor is got a false negative rate of 20%, 25%. False negative rates present in so many other diseases, non-specific. But the cyclic citrullonated peptide appears earlier. That's the question, right? Which of these is the earliest finding? And the other thing is, when you have a cyclic citrullonated peptide, it's not positive with any other diseases. There's nothing specific on the joint aspiration, nothing specific there. There's nothing specific on the joint aspiration. The joint findings are MCP, metacarpophalangeal, 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 metacarpophalangeal joints, and boutonniere deformity. Yeah, we're going to show you that in a second. It's terrible. Flexion of that proximal and hyperextension of distal, and swan neck isn't deformed, disgusting, right? Ugh, really. Look, I hope that all these things, it's my fondest hope that none of you ever see these in real life. Because if you make this diagnosis, because step 3 is an examination to make us all family practitioners all over the place. It means that if you make the diagnosis, you get that cyclic citrullonated peptide, and you start the TNF inhibitors, you start the methotrexate first, and TNF inhibitors, you can prevent all this horrible crap, man. Baker's cyst is on the back of the knee, and it's just like, ooh, just like I had a DBT. The back of the knee, it's like I had a DBT down there, but you can feel it like a bone. Okay, you can feel like a bump down there, Baker's cyst. C1, C2 spine subluxation, the questions go like this. A person with rheumatoid arthritis now all of a sudden develops upgoing toes and hyperreflexia, upgoing toes and hyperreflexia. The wrong answer is adding methotrexate. The right answer is spinal fusion, spinal fusion. The other question that goes with C1, C2 subluxation is a patient is about to undergo general anesthesia for another reason, and the person needs to be intubated. What do? You warn the anesthesiologist, hey man, don't hyperextend the head over there. Don't hyperextend the head. You're going to paralyze someone. So you warn the anesthesiologist about hyperextending that head. Now this is our, oh my God, our boutonniere deformity and the Baker's cyst down there. Hurts me. I hope these become prevented. You can't quite prevent the Baker's cyst, but you can prevent all this boutonniere deformity stuff. Now Felty syndrome, man, people love that. Felty syndrome is simply a matter of definition. It's rheumatoid arthritis, splenomegaly, neutropenia. It's a triad, it's a definition, you got to know it. People ask. Felty syndrome, just those three things. That's it, it's a fact biopsy. Kaplan syndrome is when it has pneumoconiosis and rheumatoid arthritis. Kaplan syndrome with a C, not a K. Kaplan syndrome is with a C, not a K, with nodules. Now the treatment, the first thing is this, non-steroidal, so pain and DMARDs, disease-modifying drugs. As soon as you've made the diagnosis, modify the disease. Nobody's supposed to get those horrible abnormalities anymore, so you make that diagnosis and you start the disease-modifying drugs right away. You do not wait to use them. Do not wait to use them. As soon as you make a diagnosis of rheumatoid arthritis, you start that disease-modifying drug because non-steroidals do not delay progression. Non-steroidals do not delay progression. The best initial disease-modifying drug, methotrexate. What's the most common adverse effect of that methotrexate is? Lung and liver and lung and liver and lung fibrosis and liver fibrosis and lung and liver and lung and liver and bone marrow fibrosis. Bone marrow fibrosis, which is pancytopenia. Now, even though the biologic agents like TNF inhibitors combined with methotrexate is superior, it's still not first. And the reason is 60% of patients will not need the TNF inhibitor. 60% of patients will not need the TNF inhibitor. 60% of patients will make it with just the methotrexate alone. 60% with just the methotrexate alone. So there's the question for you. A person has made the diagnosis of rheumatoid arthritis. They have the definition. They have the definition. They have multiple small joints. It's been going on for 6 weeks. It's symmetrical. It's a morning stiffy. And they have some laboratory evidence of inflammation. What is the next best step in the management to this patient? Generally, non-steroidal and methotrexate. The person comes back, but they continue to worsen. What is the next best step in the management to this patient? Add, not switch, add, not switch, a biological TNF inhibitor drug. Now, if you need the biological, what you do is you must do PPD testing to make sure you don't reactivate tuberculosis. However, if they are PPD positive, you can still give the drug even if they are PPD positive. You just start the INH for 4 or 6 weeks. You start the INH for 4 or 6 weeks, then you start these medications. Okay, you start the INH for 4 to 6 weeks. Personally, if it was a matter of having my hands deformed, I'd take the TB, but start the INH first. And you use it in combination if it fails. Now, hydroxychloroquine is another one of the drugs. It has basically two answers. One is, what do you do in a pregnant lady? Because it's safe in pregnancy. The other is the question, probably the single most frequently asked step 3 question would be, since they're not asking you when to use it precisely, the single most frequently asked question is, what's the toxicity? The most frequent toxicity of hydroxychloroquine is, in mild disease, you find retinal problems. The most common toxicity is retinal problems in eye exam. So the step 3 examination is like this. Hi, you're a general practitioner. Step 3 doesn't know whether you're going to be a board-certified internist. Step 3 doesn't know whether you're going to be a gynecologist. Step 3 doesn't know whether you're going to be a psychiatrist. But you're a psychiatrist, you're a gynecologist, you're a family practitioner, and your patient who's on hydroxychloroquine from their rheumatologist starts saying to you that they got blurry vision and funny eye findings, and you're supposed to say, man, I don't know when to use that drug, but I should know that that's a sign of the toxicity of that drug. That's what your learning point is, that you know that there's retinopathy. That's your learning point, that you should know that there's retinopathy. Now, sulfasalazine is a drug that was big for what? inflammatory bowel for a long time, but sulfasalazine is become passé because of its toxicity. Now it again has another question, which is, when do you use it in rheumatoid arthritis? Well, when they're pregnant, because hydroxychloroquine and sulfasalazine, both safe in pregnancy. They've been around for 50 years. The other thing is that toxicity. It's bone marrow suppressive and also can cause some sperm suppression. Now, the alternative disease-modifying drugs, you will never be asked when precisely to use them. One, because it's not known. Number two, that's not a step 3 goal. The step 3 goal is that you understand that rituximab exists for rheumatoid arthritis and that it can cause some infections. Now, the other answer for rituximab, when is it the answer? Step 3, let's work backwards from the answers. We work backwards from the answers because there's less of them. Rituximab is the answer for CHOP and rituximab for non-Hodgkin's lymphoma. It's also the answer for cryoglobulins. Ooh, is that cold agglutinins? Man, we're always getting those mixed up. Which one is it? Cryoglobulins or cold agglutinins? It's for cold agglutinin disease. Rituximab for cold agglutinin disease, for CHOP and rituximab, and an alternative drug for ITP, the artist formerly known as idiopathic thrombocytopenic purpura, and now more accurately called immune thrombocytopenic purpura. Rituximab is the alternative for that. Lymphoma, cold agglutinin disease, and ITP. Yes. Anakinra, yes, which you see advertised on TV quite a lot. And it's an interleukin receptor antagonist because it turns out that interleukins are like cell phone service for neutrophils. Hello, neutrophil, can you come over here and attack something? And Anakinra goes, I'm sorry, your phone call's been disconnected. What it does, it turns off the cell phone service for the neutrophils. They never get activated. Adverse effect, infection. Tocilizumab is also immunosuppressive, interleukin receptor antagonist, and you add it. These are add-ons. They're add-ons. They're add-ons. These are add-ons as opposed to leflunomide. As it's a French drug, leflunomide. Well, no, it is l'alternative to methotrexate. You might say, why not use it first? Because it's not proven to have as much efficacy. Remember, efficacy beats adverse effects, and therefore it's used in people who have the liver and lung fibrosis. Abatacept. The abatacept inhibits T cells. Now, what we see in these is, look, let's selectively inhibit parts of the immune system. Methotrexate's rather nonspecific. It inhibits a lot of it. Rituximab, just CD20 lymphocytes. And anakinra, just neutrophils. And tocilizumab, again, some neutrophils. And the other one is leflunomide as an alternative, and abatacept, the T cells. So here, let's see, rituximab is inhibiting some lymphocytes. Anakinra is the neutrophils, abatacept T cells. Now, gold salts is, if it wasn't that you were taking a step 3 exam, I wouldn't even tell you. Because it only exists to answer the question, which of these drugs causes nephrotic syndrome? It's basically a dead drug, it's archaeologic, but it can be asked as matching the toxicity to the drug. That's all, matching the toxicity. Now, steroids are not disease modifying. They're there for quick control, short term. They're a bridge to getting the disease modifiers to work, because disease modifiers can take a couple of weeks to work. And when you first describe a person with RA, that's like they come in and their joints are all red and they're totally immobile and they can even have fevers and they feel acutely horrible. You use them for a few days or weeks till their DMARD works, until their methotrexate works, because the last thing in the world we need is the long-term use of a drug that damages bone. And that is the end of rheumatoid arthritis. There's so much that's happened in rheumatoid arthritis. I think it's just, mostly I understand how it is. It's like, I don't want to have to learn all these drugs, man. They got funny names, and it's such a pain in the ass. But you know what? If you had rheumatoid arthritis, you wouldn't think that keeping your fingers straight and learning these drugs, you wouldn't think it was such a burden. You know what I mean? So if you'll just see the wonder of all this, you'll have a lot easier time, because the sense of wonder is the beginning of philosophy.